parts of the small intestine, roughly about 10 inches, jejunum, about 8 feet, ileum, roughly 11 feet. Very person to person by size. Primarily, all your absorption of nutrition takes place in the small intestine, and so your enzymes would be, and the intestine is lined with villi, in microvilli, they have a surface area, and it has these circular band muscles called the plicae circularis that we talked about, which will enhance the ability of the villi to be more pronounced, shows. And then finally we get to the large intestine. So when the ileum meets the cecum, or the pouch of the intestine, you have a valve called ileocecal valve. And it's a valve to prevent backflow. Are you late for your job?
I got right up the other day.
Fire. So, to prevent backflow of feces back up into the small intestine, you'll find this bacteria that live in this large intestine, such as E. coli, which you really don't want in the ileum because you'll have a lot of problems and side effects with that. So you don't want that. So we talked about the small intestine absorption of nutrients. Well, the large intestine or colon job is primarily involved with absorption of water. So between the kidneys and the colon, they play a big role in making the water. As you'll see when we get into your kidneys, big water balance. So this is why if you come down with some nice, Montezuma's revenge, you dehydrate very quickly. You go through about 3 or 4 quick bouts of filling up that bowl with the runs. You'll dehydrate your system very, very significantly. Okay? So, as we look at it, we have ascending, then we have the flexure right here, which you can call it either right colon flexure or hepatic flexure. Ascending, transverse colon, which goes to your splenic flexure. Descending, sigmoid, rectum, anus, and out. That's pretty much the path of your colon. Now, if we want to increase absorption of our colon, we have this band that runs around it, known as the tenea coli. What this tenea coli will do is slide and contract over itself and cause pouching of the colon to hold something there longer. And when you pouch the colon, it's called ostrum. Ostra is pouch. Okay, so it makes this pouch-like structure. So the sliding or the contracting of the tenea coli will create pouching known as the ostrum. Known as the ostrum.
You don't pick out them, let's see how it is.
Huh?
You don't pick out them, you're really good.
Because I want to pick on you. You haven't figured that out yet? God. Shame on you for figuring this out. You should know we like to pick on you.
I secretly like it.
So why is it so important that we have these bacteria sitting in our colon? Such as the E. coli. Doesn't break things down. It actually helps to form fat-soluble vitamins that our body needs. So it takes stuff and creates, such as vitamin K is created by that bacteria which we need for clotting. If we didn't have that bacteria, we would clot. So the symbiotic, when we take microbiology, we'll go into that with you. The biochemistry pathogens. Well, because they're talking about it as a pathogen, they don't talk about it as a useful. But most of these bacteria are there to synthesize fat-soluble vitamins that our body can't do. We don't have the ability to do it. So there you go. It's like vitamin D. We can't synthesize it. Yeah, mushrooms, we get, if you eat mushrooms in sunlight and eat them, it'll create a D2 conversion in the body. If it has the conversion, we don't have the ability to do it. Fascinating, that's something so important. Without sunlight is what is done. For sunlight is creating conversion. But if you can't eat sunlight, most times in the winter, everybody is reading about fish. And like I was saying, that the latest research is showing that on the Medscape in the winter, that vitamin D3 is a big cause of diabetes type 2 deficiency. And it was done in Europe and the British Medical Association did a lot of work. And they've seen that they take cases and put them on D3 and bring their levels back, the type 2 diabetes disappeared. So it wasn't just all diet related like the horse crap tells you. Some of it is due to deficiency of things, why things go wrong in our body. You gotta look at, they eat a total crappy diet is the wrong thing. I'm not saying that. But to blame this diet alone for a disease is totally wrong. There's also genetic issues with it and deficiencies with it, such as vitamin D3, that if you live in the northern hemisphere in the winter, you're going to be deficient. Because not all just heavy people have diabetes, especially in type 2. You don't have to just be heavy to have it. Stress causes. So think about vitamin D. Vitamin D plays an important role, not only with calcium metabolism, but also plays an important role in our immune systems and healthy gut. So people aren't aware of that. So, in people that suffer with chronic fatigue syndrome, vitamin D3 does help these people to build their immune system back up, so they don't feel so fatigued. And I suffer badly with D3 deficiency. So if I don't take it, I can see the difference. A lot of times in the summer, I try to be smart. Well, I'm in the summer, I said, I don't need it, so I won't take it. And within a week, energy level drops by 50%. And the Epstein-Barr virus is way back up here. So if I get back on it, then the virus attack comes down, and I feel fine. So in the winter months, I'll dose 2,000 to 3,000 units a day. In the summer months, 500 to 1,000, just for maintenance. But it does help. It helps tremendously. One time I went to the primary, went to URI, I told my I said, Frank, I feel like shit, so let's cut the crap. Let's test everything, see what's going on. And that's what came up. There was no low testosterone, was fine, the levels, all that stuff. D3 was in the toilet, and the Epstein-Barr virus was tiny, around 1,800 to 2,000, which should be under like 300, showing that it's chronic and active. And when you weigh yourself down, the immune system falls, the virus starts taking over. So, but it was never aware of this D3 with type 2 diabetics, that there was a relationship. But like the article says, this will go no further. And the reason why, there's no point to be made using vitamin D3 to treat the disease. And the same thing with water, and it was Dr. Billebeck who was talking yesterday, who's a really brilliant research person that's here, Jean Billebeck. She's had papers published in every big publisher you can think of that she's researched. And no one knows, to this day, what is the right amount we're going to take in. It's not always 8 glasses of water a day, because some people might need only 4, some people might, and the only thing they use is a study is when someone's comatose, they IV a certain amount of fluid. But is that preventing or keeping the body healthy? No, it's just maintaining life. Yes?
One thing that I've heard is half your weight in ounces. So let's say you weigh 160 pounds, that's 80 ounces of water. I've heard that's just about.
I think water like activity levels up too.
I don't agree on that. Because
Like the
If that's the case, I'm gonna fuck future Alan.
I don't agree with that. Because also became less water dense and fat. urine starts, you'll notice that in the summer on yourself. You don't have to feel thirsty, your urine starts to darken, and I'm hydrated. So, you know, depending on activity level as you states, and humidity levels around you, how much your sweat's pouring out, so that's going to vary. So that's very weak to use that as a stuff. Because BMI is going to have an effect on that too. So you follow what I'm saying?
I follow you exactly.
I mean, it gives you some type of a guide. So, and then you remember, if you eat a lot of vegetable matter and fruit matter, there's a lot of water density in that. So you're still bringing water volume into your body. Drink a lot of beer, there's water, right? No bullshit. So a lot of intestines think of a lot of absorption of your water levels, maintaining water balance in the body. So you're gonna see when we get, believe it or not, even your lungs help maintain water balance because you do exhale out vapor, which has water density to it. So it's not just kidneys at the prime and this, but there's multiple systems that work together to keep everything running. This is how I want you to keep thinking. And if you look inside, there's a good view of your rectum, the hemorrhoidal plexus. So what's a hemorrhoid?
Pain in the ass.
It's a pain in the ass.
A blood vessel.
A blood vessel that rupture. Kind of rupture, it's just a varicose vein in the rectum is pretty much what it is. Now there's some, theories on it. If you're on your feet a lot, so you can get them. If you do a lot of heavy lifting, you can get them because there's a lot of bearing down and intra-abdominal pressure increase. Or if there's a problem with your liver. How do you think that would affect it if there's a problem with your liver?
Blood vessel, the organ that filters blood, kind of, and again,
Right, you're in the right direction, but so somebody that would be having liver disorders, which is something that's affecting the sinuses of the liver, where you're not getting good flow through it, we're going to backflow somewhere. We're going to backflow into the portal system. It's going to backflow back out into the venous structure around the intestine, and put pressure, then help a hemorrhoid stick out further. So there are not all cases of like, we're going to hemorrhoid, but no. Some of it is just eating right, not enough fiber, you breathe out too hard, and you're pushing out a baby and tends to go to the bathroom. That's not an ideal situation. You're going to create a hemorrhoid. So that's the thing. So it's called because there's a plexus called the hemorrhoidal plexus, and that's how we're going to do it. Okay, so that's pretty much with that situation there. The nerve innervation, we don't care about that. So let's go into the liver. So we're going to go to accessory organs. So it's like we're going to accessory organs now. Buy a new necklace and earrings. Ooh, you got a new shirt? No, it's my necklace. So you want to buy a new suit? Accessorize, you buy a new tie. Different colored tie with a shirt. Cheaper than buying a new suit. So kind of this is what's going to do. So accessory organs mean they might have another function, but they aid the GI system. In the beginning, we talked about one of the primary ones would be this salivary glands. They're accessory glands to the GI system for saliva in there to help moisten food and break it down. Well, one of our big main ones here is our liver. Liver's got a lot of function. Yes, it does. The main thing of the liver, its main function, it's a huge detox organ. Detoxifies everything. So in other words, nothing enters the body that hit the gut without being brought through your liver to be detoxed. The nurse will relieve someday they'll teach you, but they can't leave till you get there. They're not going to like you. I'm just telling you, let you know. So, look at this picture, it's like, wow, so ugly. Okay, so we look at the picture here of liver. And again, you can see certain things in there that run through our liver, such as falciform ligamentaries, which we saw in the kitty cats. But the liver itself not only detoxifies, it's also going to synthesize molecules such as proteins, fats, and carbs. So when they put you on a statin drug, which is probably 80% of America, it's supposed to be curable for heart disease, but two have been pulled because it was a bunch of crap. They don't do anything. Two that were niacin based have been pulled by the FDA. They go on or out. The names of them, but they were pulled off the market because in a 10-year study, there was no decrease in heart attack being on this drug. No decrease in stroke being on this drug.
How did it get to be marketing for that if it wasn't effective for it? I mean, don't they have to do user trials and stuff?
Because we go to ABC One Network through Australian Medical Association. They trace all the way back to the 50s. It's all a big propaganda scheme wide.
I thought there were rules for that stuff.
There are, but here's the thing people don't realize. If I'm a pharmaceutical company and I'm going to do a standardized trial on a drug, I'm going to make sure I pick candidates that I know the drug will work. You follow what I'm trying to say? So it's a biased study. You never see, and the FDA never sees the true data of the negative of the drug until it's too late out there on the market for 10 years, or they're being sued because people they don't give a shit. They made billions, so we deal with paying off a few $1 million. We pay billions. And that's how these industries work. Remember, the FDA is no longer funded by the U.S. government because it doesn't have the money to do it. The pharmaceutical industry funds the FDA. So it's a self-policing situation that, we're friends. Are you going to do anything to me? No. It's all self-policing, and it's not being policed. So, do you believe, especially you that like to do a lot of research stuff, that some diseases have been created with some drugs?
Absolutely.
And is that sad? Yeah. That's the American way. Some of this stuff is not moved in other countries like it is here. The statin is one of your biggest. So the statin, what it's going to do, it's going to kind of make your liver sick. It's not going to produce cholesterol. And everybody says cholesterol is so bad. Well, without cholesterol, you don't make hormones, you don't make cell membranes. So it plays a very important role in keeping you going. Okay? So I remember I was at a seminar, a nutritional seminar one time, and they got on. And the doctor that was speaking gets into a patient that was a woman in her late 70s, had cholesterol of 450 her whole life. But when we broke the molecule down, the majority of it was HDL. So that 450 means crap. It's a good molecule in her body. They put her on statins, she died in 6 months. Liver failure. All right, so that, why do you think when you go on them every 3 to 6 months, what are they doing? Liver profile on you. Liver profile. And how about if you really douche the crap out of you, you got muscle pain all over, now you come down with rhabdomyolysis, where the muscles start eating themselves, destroy themselves, and we flood the kidney with protein, and you go into renal failure. So these are the side effects of these drugs. Okay? So, just to shift your HDL 10 points, you know, sometimes it's like, I don't know, I fight with my cardiologist all the time over this shit. I said, my grandfather had this, same cholesterol picture, they all died in their 90s. And I've been drunk dead of a heart attack or a stroke instead of dying of cancer or something else. That's where you don't know, go on, by the time you hit the ground, you're dead. There you're going, you hit the suffer. You know, I said, you know, the baby asked me, okay, that I can live with, you know, keep inflammation out of my bloodstream so you cut down atheroma. But other than that, I can't, you know, and I take 1,000 minutes of garlic a day, which has been shown to reduce, you know, the risk of stroke. And, you know, you gotta remember, on that side of the fence, they don't look at nutrition. But then what the first one to tell you about is that but never studied them at all in medical school, but they're bad. You follow what I'm trying to say? They don't study them at all, other than deficiency, you know, beriberi, these other diseases with vitamin deficiencies. So the liver plays an important role with all this stuff. So it's a very important organ. But being it's a big detox organ and cleans everything, I wouldn't want to really eat liver like people do. To me, it tastes like a mouthful of blood. Yuck. It's the most disgusting tasting thing. I don't give a shit how much garlic or onions and olive oil and sear this thing with. First thing, it's just like yesterday I got some hearts for some students with more hearts. And it was, you know, brought back like 12 years ago when you cut open the real human body that just passed, but unlike the ones we use, they've been pickled and sitting there, so these are full of blood, and you open them, so they just ooze with it, you gotta clean that all out of it and stuff. But one was really good, and they only paid $2 for it. It's like better than some of the ones we have that were paying like $20 for it, because they've been preserved. Kind of weird, and everything was bright red, and the papillary muscles were big and thick and strong, so relief. I mean, it really sticks out like it does in the picture, more so than it does in the ones we have that have been, you know, dry frozen there for 100 years in solution. So, and so forth. And so, but that's right. So the last function to talk about our liver is doing, besides these protein metabolism and carbs and fats, is bile. Bile is produced in the liver and stores in your bone. And what is bile? Is bile an enzyme? No. No. What is it then?
It's a catalyst.
No, that's an enzyme.
That's another time.
Right.
It's actually written out this one.
About like some from last semester. Remember what it is? Yeah.
Is it like an acid?
About emulsifier.
Emulsifier acid?
Emulsifier. And if you want to see what an emulsifier does, think of soap. So,
Check some fat.
exactly. Next time you get a skim of oil on top, get some oil, put some more water, put oil on the skin, and get the soap and squeeze it, watch it doesn't get break it home to a little tiny. So it takes something big and massive and makes it smaller, so now the light cases can get in there and break it down. So that's why we have bile. Okay, so that's the job of bile, to emulsify, but do not confuse it as an enzyme. Do not confuse it as an enzyme. One more time. Do not confuse it as an enzyme. Star! Exclamation. So, you've been warned. Okay? And we know everything drains through our liver through the hepatic portal system. And the liver is made up like triangle shape. It's got this triangles in a circular pattern around the venous structure coming in. And you have these nice pie-shaped cells. That's what they look like if you look at it, if you actually look at the histology of the liver. And if you're looking for hepatitis or damage of the liver or cirrhosis, you'll see fatty change to that. I'm not saying fatty, that people have fat that grow around their liver, they just have this problem with that. That's different. I'm talking about damage to the liver being replaced by fat cells, not normal cells. And that's what happens to people with cirrhosis or with the chronic hepatitis. You know, so the tissue dies. So it doesn't regenerate back in the liver. So the liver's not doing its job as efficiently anymore. And when you don't break, when the liver has an issue, how's the person look? Yellow, which is known as jaundice or icterus. You become icterus. And what is causing the yellow?
Surgeon
The non-breakdown of bilirubin.
What?
Non-breakdown of the liver.
Bilirubin. Now, what's bilirubin? Byproduct of what the bile is made out of, which is a byproduct of red blood cell. comes out of the red blood cell, it's called bilirubin, it's this yellowish brown color.
How do you spell it?
Yeah,
B-I-L-I-R-U-B-I-N.
Thank you, David.
It's like having, I don't remember this semester well, because one of the guys was on lab group, his last name was Rubin, a Jewish friend. And so he named him Billy Rubin. Billy Rubin. Like,
I was thinking it was spelling.
So that's what creates this, and it backs up into the vascular system, and now you turn yellow. It also backs up into your urine. So urine should not have bilirubin in it, which we'll see when we get to it. So you get this weird tea-colored urine because of the backup of bilirubin. So that's why you turn yellow with hepatic disease or pancreatic disease. Anything that can affect this duct that will not let bile pass and blow it back into your liver, you have a problem. So Houston, you have a problem.
I have a
So,
question.
what?
I have a question.
About your bilirubin?
No. Why, when someone is like in liver failure, like, what happens when the rest of their organs start to shut down? Like, why is
Well,
it
because you're not detoxified, so toxins are going into these organs. So they're not getting
Septic.
nutritious, right. You're not getting nutrition going to them anymore, so they start to die off too. Usually the most final cause of your death, not just the heart shutting down, is liver failure.
Yeah.
The kidneys will shut down. And the reason why, now the kidneys are probably most likely to get flooded with proteins. And the glomerulus cannot handle it, and the kidneys are shut off.
And what's ascites?
Ascites is, we'll get to that, sounds good. Ascites means you're very excited. No, ascites, A-C-I-T-E-S, is like a bag of fluid, its translation, means that we've backed our system up back into this portal system. And the fluid's got nowhere to go, so it starts on into the extracellular space or start filling the cavities in your abdomen. So somebody usually that's going into true hepatic failure due to secondary metastasis or pancreatic cancer, the abdomen will start filling with fluid, become big, hard, and fluid. And that even happens with heart failure, because you're stagnating back into the liver. So the point is, I hope you're realizing, each organ system depends on the next one to function. Even though we did it systemically, they all have to work together, because if they don't, you don't have homeostasis, you don't live. Yeah, I don't live, I got my liver still. No, it doesn't kind of work that way. Well, my heart's good, so I don't really live by my liver and my kidneys. You kind of need everything. You right? Left. It's like the story of what was the most important organ in the body. Is it the feet to walk around? Is it the brain?
No.
Or is it the rectum?
No.
So, the rectum, well, the story is the rectum. So, what it is like, all right, so the brain says, I'm going to shut down, and you're going to have, no, okay. And the heart says, well, I'm going to stop working efficiently, and you're going to have problems. So the asshole says, I'm going to shut down too. So, after a while, the brain says, wow, I'm getting like real foggy in here, there's nothing coming in. The heart's like, I'm not beating properly or anything. And the asshole's sitting there fine, he said, because I'm backing all this shit back up into you, and you're not going to make it. That's it. So the most important organ is your rectum. Can't clean yourself out, you're in trouble. Well, the other thing you tell people, right? Look at the mirror and look like this, and you look like what you are. That's what that is. So, our next important organ, and hope to hear, is our gallbladder. And the gallbladder is going to store the bile. So, when we eat a nice fatty meal, you're going to push out a lot of bile. And for some reason, you have a stone in there, it don't come out. And it goes in spasm, and you feel like hell. Healing all over the place and stuff. And it's due. So you have a, now, depending on when it becomes a medical emergency versus elective surgery, is depending on where your stone is. If the stone is here, the elective surgery. The stone is here, it has to come out, because you're backing everything back up to the liver. Here it's not going back to the liver. The liver will still pour some bile directly through your bile duct from the paddock to bile. But if it's in that common right here, you've got a problem. Or the stone makes it and flops in here, that's a medical emergency. You're going to be rushed right in and it's going to come out. That's the person will turn aqueous, the person will get secondary pancreatitis due to this everything. They'll be really sick. And amylases, urinary amylase, blood amylase will be through the roof, enzymes through the roof. So that's a medical emergency. That's going to be fixed. So if it becomes a medical emergency, that was a case study I gave that they wrote a paper on about two semesters ago, last fall, not this fall of 15, fall of 14. I wrote a paper on global thighs, and depending on where it is what the problem is. So depending on when it becomes a medical emergency or not, and that was part of what they had to do when they went through the article and write a story and tell me, when is it an emergency, when is it not? How can you live with it, and so forth. Why does it cause pancreatitis, and so forth. So there you go. So there's a lot of interest in this area. And again, we say to have more bladder diseases, the 4 F's. Female, fat, 40, fair skin.
What was the last one?
Fair skin, lung.
So it can't be that important because they take it out.
Oh, you don't need it. You can live without it. You just shouldn't eat as much fat because it's going to strain the liver more, but you can still eat fat foods. But I wouldn't make a habit of eating like a big bowl of something that's a big ball of fat. In comparison to having a little bit of it's not going to affect you. Now I had one of our office staff people, she was only like 20 years old, they had to take hers out. And she, after they take it out, they discharge her around the nostrils, and 2 days later she's rushed back in with the gallbladder sensors again. So when she's in the ER, they say, well, it's in your head, because you don't have to go back. Well, she was not in my head, because I can't even stand up, and I'm throwing up, and everything, and my eyes was getting swollen and stuff. Well, when they went back in, they closed the wrong duct. Instead of close this duct, they closed this one. She was dead. Right, she could have been dead.
Get a big fat cell for that, that's pretty bad.
No, she didn't, but she should have.
That's a really big stroke.
So, yeah, it is. So when we go from our from there, we go to our pancreas. Or pancreas.
Arse. English accent, pancreas.
So the pancreas also plays an important role with digestion because all your enzymes come from it. So its exocrine function is digestive enzymes and buffer solutions. Why would you need buffer solutions? Exactly. Because when that liquid acidic chime is flowing in, you got a real low pH of probably about 3, maybe 4.
Pump that acid.
So we have to pump in these buffers to raise this pH, because if you don't raise the pH to at least around 6s,
It'll destroy the organs.
and not only that, the enzymes aren't going to work.
So exocrine function.
So exocrine function is buffer solutions and digestive enzymes, which would be proteases, lipases, amylase. Okay, so that's what it's going to pour out. And in physiology, unfortunately in physiology, the GI tract, the most important thing, you never get to it. Because you take so long to get through the systems that the last thing you talk about for about 5 minutes is kidney and no GI tract.
They don't talk about the endocrine system at all.
No, that's why we're going to talk about it anyway, so last week we spent a lecture on it.
Could you repeat those 3?
What's
Or
that?
did you say amylase, what else?
Amylase, lipase, proteases.
Thank you.
Okay? So, there you go, in buffers. Because we talked about an experiment that you'll do in physiology, and it's when you take amylase and you're going to break it. See what happens if I put it in acid. So you're going to add like an ml of hydrochloric acid to it. One, you're going to heat it. One, you just put water, one, you just leave it alone. which one should work the best? And you're left alone. Because what happens, though, you kind of screw up and you kind of all stop working. It's like, well, you kind of cross-contaminated, that's why nothing's working, you know, which students do. You really learn how to not cross-contaminate when you finally take micro. Because they work on that for
You'll
weeks.
know.
You'll know that nothing grows, or that every bacteria in the world is in one place. So you kind of screwed up. You know, so you didn't use your inoculation meter properly. But the point is, if we play with temperature or we play with pH, enzymes don't work. Why? They denature. Because primarily they're proteins. Not all, but primarily they are. And you denature a protein so easily with temperature and pH change. So if you denature it, it don't work. And when enzymes don't work, things don't work, and you say goodbye. Now, the pancreas and gallbladder will secrete through a common duct. As you see, they hook together at the head of the pancreas. And they have the common hepatopancreatic duct, which is going to become, you have an ampulla and you have a sphincter. So you have the sphincter, which pours, you know, the ampulla, sphincter's here, the ampulla's here, then it pours up. Well, there's other names for these. And the sphincter's name is called ODI, O-D-D-I, just like Garfield's dog, ODI. And so you pour through the sphincter of ODI, and you end up in the ampulla of Vata. Instead of saying water, you say Vata. Like you have a Slavic accent, so you say, I'll have a glass of Vata, please. Yes. Yes, Sweden.
So is that doorway?
Odie's the doorway, and Vata is where you end up. So in other words, if this little alcove right here is Vata, this is Odie, and now I'm in Vata. Spell it V-A-T-E-R. So it's water would take the W away and put V. Vata. And they'll use that in medical literature. You read about gallbladders and communities, you know. So now can you see why a cancerous tumor in the head of the pancreas you're trying to screw? All right? It's going to close all this off. And what's it going to do? We're going to affect this. This is not working anymore. We're going to affect this. Food's not going to go through here. So they shunt everything just to keep you going until
But you don't.
you die of
Picture
pancreatitis.
was like it's like right in
Yeah. Yeah, if it's in the tail, you got. If it's here, you'd have a good mortality.
Yeah.
But if it's in the middle to the head, yeah, because I had a friend went to isolate and he died in 8 months. The diagnosis. It was in the head. Yeah, they put the shunts in to make him comfortable. And he was a healthy person. He ate healthy, did everything right. Died. 59 years old. He had cancer like a couple of years ago. So, doesn't make a difference. He had money for the best of care, went to Boston, and there's nothing they could do. The shunt is to make you comfortable. Because if you don't shunt it, the enzymes back up into the pancreas and start dissolving the pancreas, they pour out into the abdomen and start dissolving organs, and pain can be excruciating from it. So by shunting, you eliminate that. But eventually it gets to the liver. And if it doesn't just stay there, it eventually goes to the brain. Because the blood supply is so good to get to the brain. Okay? Same thing with people, you know, they like the brain. They get to the spinal cord and they follow their way up subarachnoid space to the fluid to the brain. So they're nasty tumors. They're not nice at all. They just don't like you. And what's the other thing on the endocrine function of my pancreas? Insulin and glucagon. Insulin and glucagon. Insulin lowers blood sugars, glucagon raises blood sugars. And these come out of your islet cells.
Insulin and what?
Glucagon. No, she asked, what it does or what's with it? Is that what you were asking?
Just the word, yeah.
Oh, okay. All right, so not physiology, but I'd like to throw a little function to you like you just did. So your main thing is to know
what is an organ that which is created endo and exocrine function in the gut, and plus other solutions? What could it be? A pancreas, okay?
What is the only thing left that we didn't mention that's in our abdomen that has nothing at all to do with digestion? What?
Spleen?
Spleen. Appendix. Spleen.
Explain the spleen.
The spleen. The spleen deals with blood, immune system, lymphocytes, storage of red blood cells, breakdown of red blood cells. That's what it stands for, the spleen. Red blood cell storage, immune function. Just think of that. And what's the most prime cell for an immune function? Lymphocytes. Lymphocytes. But they don't just come out of the marrow, they come out of your spleen too. Okay? So that finishes up. Thank God the GI system. Finally.
We're like 10 weeks behind. Don't worry about it.
So now we'll go to the heart. Right? The heart. That's what the thing going to be, right? No. Is it the thing going to be? All right, so go to the cardiology section. You know, so really a heart is a very important structure. You can't fall in love without. This is what you guys do with me. Wow, it's like, can you show me again? She says she's pregnant for 7 times. So, pretty much, it's very important. In most of the careers you're going through, you're going to deal with this. Well, any other thing, you'll deal with this. So you could stroke with it, whatever, yeah, but the cardiac section is very important. Still the #1 killer in this country. Still the #1 killer is heart disease. Why the hell knows why? You've tried all these things and it still keeps getting.
When you look at it across other countries though, like other countries like
It's not.
Asia and stuff, it's not, okay. So it's gotta be like diet and
Diet, I think lifestyle more than diet, lifestyle is such a stress. I think it's an organ that's very vulnerable to stress. Compared to any other organ in the body, I think it really is. But when you stress, I really believe it causes something. I'll get some people coming in all that stuff. Okay, that's what you like to do is to write stuff, but you learn from what they write. Because you don't have time constantly researching. I'm researching anatomy. Today found a real awesome book, but I said, man, it's too late now. The book is really awesome. It's used in University of Michigan medicine, but it's a great clinical anatomy book. It shows our stuff in a much more compact, right up front fashion. I said, damn. Maybe eventually we'll make the shift over to it. So, and the price of it brand new is $79. Used it's 45, the 5th edition. So, we don't care about the diaphragm. Here's our heart. Where's the heart sit? Mediastinum within the pericardial cavity, correct? So if your choices are on a test, you use thoracic, pulmonary, or pericardial, where you're going to put it in. Pericardial space, right? Makes sense. It's the most, but if pericardial wasn't there, then what would you put it?
Thoracic.
Mediastinum.
Oh.
If mediastinum wasn't there, then you go thoracic. You follow what I'm saying? So,
I smell what you said.
like a dog. His nose is cold. So, for most of you, you'll be listening to heart someday, I hope. And when you put it there, it's not just to look impressive, but I look cute in this color stethoscope. Put it out somewhere. It's amazing why people like to walk around with these things around their neck, and most uncomfortable things just dangle around you.
And if it drops, you have to pick it back up.
Right, exactly. So, this, you know, think of an example, you can grab the one that's there and use it, it's easier. I understand the thing, hey, about talking in your pocket. It's a fashion statement, you look cool, right? Going out in public with your scrubs on, who's your dog? No, they're just comfortable pajamas.
I have a friend who literally, he's an engineer, like, he bought scrubs.
Yeah, because they're comfortable, they're very comfortable to be in. They really are. They're comfortable, much more comfortable than clothes.
Yeah, but he also tells people he's a doctor, and I'm like, what are you doing? I watched him do it.
Well, he is a doctor, he puts fixes things, creates things, so there's different types of doctors.
Don't hate on this game.
Right. Get some dates, then there's nothing wrong with it, okay. Then the problem is you're not gonna tell them the truth. Oh, well, that's where you get caught. When they're caught lies, you're going on dating. But looking at this, when you place the stethoscope over the chest cavity, you kind of want to know where I am over a heart. So if we go to the right side, right, is your right side, is my left. So if I go to my right side of my heart, where would that be? Your aorta. Go to the left, pulmonary. Kind of weird that it's like that, but it is. Then here would be tricuspid and mitral. Right in this fifth intercostal space at the MCL, or your ventricular line, you find that's also known as the PMI, the point of maximum intensity. Because you're right over your ventral, especially your left. So you really get a lot of impulse pushing up against the stethoscope. In a real thin-walled person, you can actually feel the heart beating against your hand if you put it there. Just like, see with vascular, someone, you know, putting out a big pinch of his belly, they're laying down, you can literally get on each side of the umbilical and go push straight down, and you'll actually feel the abdominal aorta beat up against your fingers. So it's beating straight into it, like this. Usually it's a normal aorta, but it's beating in a fashion like this. You know, anyways. So this old-fashioned way, without all this fancy technology, doctors would figure out what was wrong with it. We spent a lot of time for this on physical exam because we didn't have this crap and all this. So we had to use this computer versus this computer. So in today's day and age, yeah, technically these doctors are smart, but I have more respect for the older doctors because they didn't have this. You have internet. When I took anatomy, I had words, not even pictures, words to read, to figure out what I was looking at. Very few pictures, maybe words, or a little drawing, you know, but nothing that was like what you guys have. So it's like your managers, you have so much more access than I have. But you know what I think that happens to you? You over access. And then you don't know where to focus on. You have to, sorry, I'm saying that you have to use what works for you. Just carry that with you from scientists to get out of here. Use what works for you. Don't really your friends using this internet thing. You're using this and you're doing well, that's all you use. You don't need that. That's the point I'm trying to make. Everybody does a million things, million this way, that. All you do is confusing. You're overloading your brain and confusing yourself. My easiest way to learn that, draw it and label it, draw it and label it, draw it and label it. Do it over and over and over, especially things easy like nerves, vascular. It's just a roadmap. Draw it and label it, draw it and label it. Now you understand the region it should be in, and that's the only damn thing it can be that's pinned in there because that's all I had to learn. That thing. Just like rule out the only thing on the right posterior thoracic wall is blue is the zygos veins. Nothing else there to name. The only thing on the left that would make you learn the little white thread, that was your sympathetic nerve. So you can name this stuff without even looking at it. You look, oh, okay, there's nothing else there. Boom, done. But no, we have to get caught touching it, I gotta yell at you. You know, it's like, You don't have to. That's the point. You don't have to. If you keep drawing it and labeling, drawing it and labeling, get in your head, it's the only thing that's in that region, don't you're gonna know. If we're looking at, why do we want to focus the right atrium? Because there's two things, one of the two things are gonna get asked in there. Either coronary sinus or fossa ovalis. So why is it such a damn mystery when you look at it a day of the practice? Hot spiral shaped, right side. Flat one will be my left side I'm focusing. Duh. So when you're walking towards it, right in your head you go, boy, if he's asking me valves, it's going to be either the aortic valve or the mitral valve. You should be thinking that before you even walk to the specimen, so when you see the specimen laying there. If it's the right side, it's going to be tricuspid and pulmonary, it's going to hit me with a valve. Quarter tendon on either side, papillary either side, trabecular cardiac either side, that don't make a difference. Why is that?
Said a lot of pre.
If you break it down that simple, if you go to the bathroom here, if you go downstairs into the cafeteria or you go in the men's room, go in the men's room. Or if you go in the ladies' room. That's where the toilet bowl should be. Not in the cafeteria. So why would I name, and this is the biggest mistake I see, I'm going to tell this to you now, the biggest mistake I see, is you name one valve right, and the other one doesn't even belong there. So you figure it out as a tricuspid, then how's this one in aorta? It's next to it. Can't be, it's on the other side of the heart, you can't even see it from there. You follow what I'm saying to you? So if you put them in the same room and you make your guesses, you're going to guess right. But if you never thought about it and put them where they belong, then you're going to guess wrong. Because as long as you put them in the same room, I don't give a damn how nervous you get, you're still going to guess right. So there's different little things that work with an animal. Some that the second time they realize they find their niche, now they're doing well with it because the first time they couldn't find their niche. It was getting blown away every test they took. Finally they start sitting back saying, oh look, I made more of this damn course than what it was. And you sure as hell going to say that to get into your nursing school. You're going to say, oh my God, this course was like something from kindergarten compared to what I'm doing now. Talk to any nursing student right now and ask them the level of intensity of what they're studying now to what you got to do for this anatomy, physiology, micro. There's nowhere near. The level of change is so drastic. It becomes a full-time job while you're in school. Between your clinical and your theory, it becomes a full-time job. Okay? So just start making things make sense to you. You know, of course it makes sense, you know, because she studies a certain way and she doesn't mean that way is going to work for you. You have to find what works for you. So there's different options. Some people like flashcards. Oh, she's doing flashcards, so I should do them because I'm. Did you ever study that way? No. Did you do well? Yeah. I said, why are you going to go that method? That method's not going to work for you. If you're a person that's very visual, I should have drawn it. Just draw sticks, lines. Just label it. You know where it's supposed to. Draw it if you're a very visual person. If you're a very type person that likes to be more think about reading it, then the cards will work for you more. Because you like reading the word, then looking for it. That'll work for you. So you listen to me. Because you know this final practical can be a lifesaver for some of you. Not all, some of you are in really good shape, but some of you, for the borderline student. So it can pull you up, because really in my eyes, this is probably the most easy, visual, practical of them all. Because this stuff is very visual compared to the other stuff. It's stuff that you've heard of. So we put it in a pericardial sac, right? And this sac is lined. So we're going to have a lining that faces the wall and a lining that's on the organ. If it's on the organ, it is visceral pericardium. If it's lining The wall, it is parietal pericardium and it has a space. Pericardial space which has a viscous fluid in it. What happens if we mess up this viscous fluid?
And you have friction.
You get friction. And when you get friction, is that good?
No. Well, not for this.
Is that? And if you do get friction in there, here's what's going to happen. We're going to have a condition known as acute pericarditis of cardiac tamponade. And why is this bad? Because every time the heart contracts, the fluid thickens around it and the heart can't re-expand itself. So eventually you strangle the heart. Very painful condition. And the triad of it is known as Beck's, like Beck's beer. Beck's triad, so they will remember that now. Beck's triad. Same spelling as the beer, B-E-C-K-S, Beck's triad. And there's three things that go with it. You're going to get decreased blood pressure, muffled heart sound, distended jugulas. So the person's got a lot of discomfort in their chest, but they have this triad versus an MI triad. A little different. It's right there. Right, so that's Beck's triad. So if we ask a question about what disease would you look for with Beck's triad, you're not going to say congestive heart failure, acute MI, you're going to say pericarditis / tamponade. And this is usually due to an infective process. Somehow, and this is how the flu kills a young person, because the flu can get into your heart and it can kill you.
You're saying that's how Prince died.
That's what she said, because she did the autopsy. She wanted to see what he looked like now.
Quiet, I'm in mourning.
Yes, David. David has a question.
When did they change it from pericardial to tamponade?
What did I guess? Year and a half.
Really?
Yeah. I know. They liked it. And before that, you looked for FEM instead of this.
Yep.
Fever, anemia, and now they've changed it. Why? I don't know why. Because that's what I was taught. Pericardial tamponade. I was taught the same thing. But one day I was reading, I said, wait a minute, I'm going to tell the kids the wrong thing. It's this now.
Because it has to go, they have to.
Well, they got to remember that your job is needed, so you have to change the name. You don't change names, you get rid of it. It's like you have to shut the power down this weekend here, because they're going to fix something. Well, they didn't do that, they don't need that person to fix something. So, that means my computer won't work on Monday. So, that's usually what happens. So just remember that in the back of your head. So now look at this picture, and look at this picture. Look at the identical. This is so ugly, there's no color to it.
It hasn't been
Showing
dyed
that
yet.
the mediastinal space, your lungs are much more posterior and lateral to the heart. And there's showing that the cardiac muscle bone. Now look at the real heart versus our pretty heart. Ugly heart, pretty heart. Right? Ugly girl, pretty girl. No. So, the point is, we have three major vessels that come off the top of this arch. And you're going to see today, for some of you, the cap has two. You have three. We have a brachiocephalic, a left common carotid, a left subclavian. The kitty cat has a brachiocephalic and a left subclavian. His common carotid or hers comes off the brachiocephalic. So when you hear the term brachiocephalic, what should you think of? Arm and head, right? So it's not a mystery how these things get their names. Why do we call it subclavian? Well, because it doesn't require one. Why do we call it axillary? Because it goes to the armpit. Why do we call it brachials in the brachial part? Why do we call it radial ulnar? Because it runs near the radial ulnar bone. Like a lot like common sense, isn't it?
Common sense is not common.
No sense. All I'm trying to say, is that hard to remember that, to hear? No. Not really. Think of where it's going, what it's doing. Okay, so that's what I'm trying to get across to you. You're gonna look at it and go, oh my God, they're two sheets. Big deal. Never heard of a kidney? A urine, bladder, urethra? Never heard of that? Right? Never heard of a testicle? A penis? A urethra? A spermatic cord? A vas deferens? Never heard of these things? Prostate? Nobody's ever heard that in this room. Or a uterus? A fallopian tube? An ovary? I like when people go, I don't know this here. I said, well, you're female, you should know this. Well, I can't see it. I said, yeah, you put a mirror on the floor and stand right there. Oh, damn, got it. Got it. That's it. One for me. So we look at this. We have our sulcus, right? Our interventricular sulcus, which is going to carry a real true important artery to us. This one here really plays a big role in saying goodbye to the world. What this thing includes. Way up at this point here, because it wipes everything out on this left ventricle. And then we're going to see we have our left and right ventricle, our apex, here's your base, here's your auricles. Auricles the outside, the atrium's the chamber on the inside. Simple. Okay? On your practical, if you write auricle or atrium, you get it right. Because to me it's synonymous. Don't worry about it. You have more important things. Then, why is this blue and that's blue? That's a thing, that's an artery. What the hell? You're screwing my brain. Where? Carries it to the lung. So we know we always enter a building through the atrium. So we enter our hearts through the atrium. The only way I'm going to get into atriums are through veins. And the only way I'm going to leave the heart is through ventricles, and that's through an artery. No matter what type of blood I'm carrying, that's it. That's a given. That never changes. You got that? Veins always enter, arteries always leave. That never changes. So I enter and I go in, the first room I go in is the atrium. And then when I want to leave, I go through the ventricle. So that's a given. So this blood has to be crappy. You don't have a lot of oxygen, so this is blue. I go into the pulmonary trunk, and now I go. If I was leaving the left ventricle, I through the aorta, and through those three branches into the systemic circulation. When I return, I come to the superior, inferior vena cava. And these are nice and red, because those are pulmonary veins, and they're bringing oxygenated blood back to the heart. So then we have a little thing here called ligamentum arteriosum, which once was the ductus arteriosus in fetal circulation. We'll talk about that with the fetal circulation. But you see these structures on your heart in the lab.
That's the umbilical cord, right?
No, not that.
Belly button is in.
The belly button.
Right.
Good part of your belly, little cord. Okay. Now looking at this, we should know where we, if this didn't even say right, the right atrium. You can't see it. All right. We know we're there. Why? Because why? This, because of its positioning. It's a given. So when the heart is in that plane, that's what I'm going to ask you. Because you can't see it in a coronal cut. I only can see it in an oblique cut and tear everything out. Yes, it's difficult. There goes the 100. See that wrong? So I get 96. You did. Right?
What's this, 97, John? I'm not that.
About 65 questions. It's got to be more than that. But do you feel what I'm saying? So this is giving it away to you. Because you know you're in the right atrium. And you're going to look for these specific, in the fossa ovalis once was the hole in the heart known as the foramen ovale in the fetus. And damn fetus. There's a lot of problems. Now we look here. This is a broken heart. So we know this is a female. The gender besides female because it's broken hearted. If it was male, nothing would be here, this words. It would be a white blank page. Which is nice box. It'd be a nice box. That's good. I'm going to find a nice box. Put it up there for next time. Female heart, and then here's the male heart. Nice box. Block of ice. That'd be a good power. So, under the sulcus, we have the septum, the wall, between the two ventricles, right? Not intra, ventricular. Inter means in between. That's, right? That's the Greek. Yeah. So, there it is. We have papillary muscles. Now, does chorda tendinae, trabecular carinae, and papillary muscles change no matter what side I'm on? The answer is
No.
no. Does the name ventricle change? No. Just either left or right. Atrium? No. Left or right. What is changing? The four valves. Not the four seasons, the four valves. Frankie Valley and the four seasons. Four valves. And if we look on this side, we have pulmonary and tricuspid. Because you try it before you buy it. The bicuspid's here, tricuspid's there. And the aorta's tucked over here. And these two are like kissing cousins more than here. If this is really in a normal tissue layer, they draw this like this because you really can cut the heart into a plane to see this. There's a good inch between these two valves. These two valves are touching one another. So when we cut the heart in this plane, usually this is gone. And you see this side of the heart only.
Is that what we're going to see?
Yes. So when you get a heart cut in the coronal cup, people, I'm really focusing on the left side of the heart. When I have it in a spiral cut, where it's twisted around, I'm really focusing on a right side. And the whole heart will sit in a plug. So you know what's the front, sitting there right facing. The Sam's like, oh, we should do the plug from the posterior.
What?
I said, no, Sam, that's too much.
Awful. Just awful.
Oh, what else I can plug? What are you doing with it? This stuff is awesome, but I don't read through all these comments. Never take in, it's nuts. All right, notice the difference in the wall thickness. Bless you. I didn't hear you. Say bless you? Okay. Go swing tight. Much better. Okay, so, what do you think? Why would the left be thicker than the right?
Because the left has to pump out the blood.
And the right doesn't pump it out.
To the bottom.
So do you agree with him, the right don't pump it out? Just the left does? Why? You failed. You were right with one part. Go ahead.
The right pumps things into the lungs, where the left pumps things into the systemic.
The whole body. Right. So it's got to pump further. But they both pump. You were on the right track in the beginning, and you derailed yourself. Train trick crash. Good job.
So the right is thicker because it pumps.
Right pump, yeah, we're going to do that in a second. Right pumps, that's what we'll probably finish with today. Right pumps to the
The lungs.
lungs, left pumps to the body. And we'll go through tracing on drop of blood, because that'll make you happy. Okay? So, and this thing right here would most likely be a coronary artery, but you can see when I have it cut in half, you'll see one flapping this way. If there's a stick in there with a little tag, I want coronary artery. It's amazing how it becomes pulmonary trunk, brachiocephalic, becomes everything that it's not. Well, you show me if that would be sufficient enough to push all my blood to my lungs. No. No. Or to push all my blood into my brain and upper extremities.
No.
No. So why do we call it?
Depends on the brain.
Be nice.
Because our brain tricks us. Because our brain is very evil.
He's gonna eat. Those drinks themselves. So where do we go from here? So let's talk about a murmur. There's our valves. And what is a murmur? Yes.
The heart has an irregular heartbeat. Kind of it'll beat a little bit and then it just passes out like that.
Do you agree with that?
No, an arrhythmia is a regular heartbeat. I remember when you had an extra beat or an echo.
It's like a little flap, right? Somewhere.
And this bullshit.
She's got a flap. You came
I
close.
have an arrhythmia.
Yeah, no, you're close. I did not say you're off, but you're close.
It's like a hissing sound.
A murmur happens when there's a backflow of blood into via the valves, so the heart has to pump even
So that would be like a flap, which you say in flaps back. How about we just define murmur and forget about the heart?
Oh,
And just say what a murmur is. A large volume of fluid being passed through a small opening which creates a sound. A large volume of fluid being passed through a smaller opening which creates a sound. Does that make sense to you? She's smiling. She's happy. It's almost over. I don't have to look at this bowl, Professor. Or the kid Vito. Get up there, come out there, go, are you Professor Vito? I was hiding himself. I'm not only 5 feet tall. Some other adjunct, I guess you never met Vito, any of us, I let her in her lab, and let you thank you, Professor Vito. And today I was sneaking away at our meeting things, and never saw the president, to that day sneaking away, he was in the hallway, the president. Hello, hi, I'm Professor Vito, nice to meet you. You laugh like hell when I tell you all this stuff. But it's all right. That's your definition of a murmur. Apply it to the heart, and then I'll tell you if you're right or wrong.
Isn't a heart murmur when one of the valves closes slightly later than it should? So like a little bit of blood will squirt through the small opening
All right, so you're regurgitating it.
through the partially closed valve.
All right, so you're regurgitating it. And how about if it's stenotic what's happening? I didn't say stenotic, I said stenotic. The Italian students.
What about?
It doesn't open all the way. So either one of those will make a sound, correct? So you can hear it.
Is it like a hissing
So the
sound?
normal heart valve closing sound is love, duh. If these close first, you hear love. When the semilunar is closed, and you hear duh. So, thinking of that, what do we mean by, now you're all talking about arrhythmias and things, so that means you know a lot about the heart, so you can teach me now, because I don't know anything. So, what do we mean when the heart's in systole versus diastole? What does systolic mean versus diastolic?
Has to do with the pressure in the atrium.
Okay. So why is that giving me an answer? I'm just confused.
Isn't a comparison of the blood flow going into the blood coming out?
Okay.
Isn't diastolic when the heart is at rest?
Well, right. So diastolic means the heart is of course the word not in my head, the word, but it's at rest. Okay, we'll put it at that for now. And then the systolic is when it beats. So why do you think when you're looking at blood pressure, you're so concerned with blood pressure when that bottom number is always high? Why is that a bad thing, Dave?
Because it shouldn't be overactive. It should be resting. Otherwise, you're going to blow out.
Like you're resting right now.
Nah.
All right, so he's on the path, you're resting. Okay, so why do you look at blood pressure that's this over this?
Shit.
They're concerned.
Because you're going to blow out.
How about blow a little blood vessel in my brain?
Aneurysm?
Well, it could create it because of pressure and atherosclerotic change, but why is this so bad? I don't understand. This is bigger.
Because your heart should be resting. Because
So what is the magic word I'm looking for? The pressure in the
Pressure.
system isn't coming down. So think of a pressurized system that works off pressure, like my car, your hydraulic systems.
there's not enough blood.
And if there's too much pressure, what happens to the line? It blows. And you replace it. Well, when it blows on, it's kind of hard to replace. You know, we blow out a major vessel in us. If depending on where it happens, they need help us, or you just drop and you're gone. You know, depending on where it could be. So the reason they're concerned about this, they'd rather see it sitting like here or less. And unfortunately, the majority of the population don't have this. We does. Oh yeah, because I'm saying when I'm medicine, that's cheating, David. That's cheating. That's cheating, David. So more people will sit more here then there. And for years, this was okay.
That was the norm.
No, this is the norm. And they're putting people there, and heart attack is still happening. And stroke is still happening.
So I guess 110 over 60, 100 over 60 is going to be the
So I just make us dead, and we have no pressure on the fine. The point is, normally when I was in school, this was your normal range. And you're over 60 to 140 over 90. This is still here, but this now will become more like that for your height. If you're like here, you're pre-hypertensive. Where years ago, that was pre-hypertensive. It's bad too, yeah. Because you're not moving up, the heart's going to beat more to get the pressure up. So you usually have more radical heartbeat and anemia. Okay, so we'll finish up going forward on this on Wednesday. So have fun.